イントカードはお持ちいらっしゃいますか？
はい。そのままでいいですか？
はい、それでは。はい、ありがとうございます。ポイントはお試しでよろしいですか？
はい。
はい、440円になります。440円ちょうどいただきます。
何ですかね。
Increase the small bell as well as increase the resting tone, thereby decreasing the distensibility and halting the normal peristalsis. Dopamine appears to show some effect because it becomes an adrenergic effect over about 5 micrograms per kilogram. Many people are using 3 to 5 mics to increase visceral perfusion, but once we go over about 5 micrograms, we start to see an adrenergic effect. And of course, the adrenergic effect to the visceral blood flow is significant shunting of visceral blood flow. Remember, just putting someone on an operating table or putting someone in an ICU under stress shunts about 50% of their blood flow away from the GI tract. Putting them on 10 mics of epi or 10 mics of dopamine does pretty much the same thing. Shifts about 30 to 50% of the blood flow away from the GI tract. Clonidine works by blocking the parasympathetics. Psychotropic drugs, which Many of our patients come in with a residents now coined thinking medications. Well, we know post-op they're going to have a significant dysmotility because they get altered ability there, and basically they're blocking the cholinergic receptors in many cases. They want to get back on these right away. We don't really know the mechanism for acute steroid withdrawal, but there's a significant dysmotility with acute steroid withdrawal, and I wish I could tell you the mechanism. I don't really know. Well, what about agents? What should we be using? Well, unfortunately, Reglan, metoclopramide, has been done in about 7 prospective randomized studies in ICU settings and have not been shown to make a significant difference. So giving Reglan routinely probably is not indicated. What about erythromycin? Well, the data for erythromycin is a little bit better. The problem with erythromycin is if you're on pressors, if you're hyperglycemic, you lose the benefit of erythromycin. We don't see any benefit if patients have a blood sugar greater than 200 or if they're on pressors for cardiac support. So we lose it there. There's 2 studies that actually show benefit. Obviously erythromycin works through the motilin receptor, causing contractions, or a fairly violent antral contraction, causing gastric emptying. The effect of it is not prolonged. Usually you can get the effect of the increasing the migratory motor complex contraction in phase 3 for about 2 to 3 weeks, and then you lose that benefit. But again, you have to have good glucose control, and you should not be on pressors to show an effect with erythromycin. Octreotide is an interesting one. At high dose, we all know is an inhibitory peptide. We use obviously octreotide is the octapeptide of native somatostatin, which is a 14 amino acid peptide, but the half-life for native somatostatin is only about 2 minutes. Octreotide gives us a much longer half-life. At 25 to 50 mics, we get enhanced motility with octreotide, and once we get to 150, 100 mics, we get inhibitory effects. So it has a sort of a bimodal effect. At low dose, it's enhancing motility. At high dose, it inhibits motility. Neostigmine is getting a lot of press lately. We know we use it now as pretty much the routine for Ogilvy's. Once we've ruled out obstruction in the colon, once we've ruled out an organic cause of obstruction, neostigmine works very well. Although the problem is make sure you got them on a monitor because you get profound bradycardia, and it makes everyone very nervous when you give that 2 milligram dose for acute and you see them brady down to about 20 for about 30 seconds, and then they start to come back. So neostigmine works very well, but now there's actually 2 papers published, one in a prospective randomized literature, the other was presented at DDW. We're using low dose, 0.4 to 0.6 milligrams per day over time to give us better colonic contraction. Actually, some pretty good data coming out, so that may be something to watch for. Remembering the problems with neostigmine, though, bradycardia and hypersalivation. So you're going to increase your respiratory secretion or your upper tract secretion, so you got to be a little careful with that. Make sure you've got patient on a ventilator, make sure they're suctioning adequately, etc. And then cisapride, of course, has been off the market here except for compassionate use. I think we already mentioned that erythromycin effects are altered by catecholamines, and again, we don't get much long-term effect with it. Also, the problem, of course, is it being an antibiotic, you worry about resistance using it. Now, some of the newer ones actually don't have any antibiotic side effects, these ones in phase 3 trial now. Okay, what about nutrient delivery? Well, it's dependent upon lots of things, and the ability to deliver the nutrient obviously is one of the big ones, but the location delivery, gastric versus small bowel, the metabolic demand, and the efficiency of utilization, well, all of these are going to be affected by GI tract motility. Why should we bother? You've got a sick patient. TPN is a piece of cake nowadays. It's no longer a mystique or a science. Every intern in the world can pretty much write TPN. So why should we just give them TPN? Why should we worry about these risks? Well, I think the data is very clear now. In every randomized prospective study done to date in ICU patients, every one that's done in a good job, peer-reviewed literature, there's now 9 published, lowers your infectious complication when the GI tract is used enteral over parenteral, cuts it anywhere from 14 to 48%. That's clear. We can lower infectious complications. Maintaining the gut-associated lymphoid tissue is probably the reason for that, at least one of the main ones. Maintaining mucosal barrier. There was just a paper this month in the Annals of Surgery and one in the Journal of Parenteral Enteral Nutrition showing us that dripping small amounts of glucose across the mucosa enhances visceral blood flow and protects from that shunt of blood flow away from the GI tract. It attenuates the hyperdynamic response. It lowers the response to the identical stimulus. Very nice work done out of Cornell in New York where they basically put half the population on enteral, half the population on parenteral. These are stable, healthy individuals brought in for volunteers. How they volunteered for this, I don't know. But then after 8 days of enteral versus parenteral, they injected them with endotoxin, 1 dose of E. coli endotoxin, and looked at the metabolic response. The group that got parenteral feeding had a 25% higher metabolic rate to the identical endotoxin stimulus. So it's clear now that GI tract use lowers the metabolic response to stress. Obviously, everybody in the ICU is in stress. Better glycemic control, gram for gram nutrient.